We're here at the Society of Hematologic Oncology Conference here in Houston, Texas, and I'm going to be speaking today about non-antibody-based therapies for multiple myeloma. These really focus on 3 drug classes, and they're all directed towards BCMA, which is a great target for myeloma because it's specifically expressed on plasma cells and very few other cells. So the main classes of drugs that we have available for this indication is the CAR T-cells, the BiTEs or bispecific T-cell engagers, and the antibody-drug conjugates. Now, none of these 3 is FDA approved yet, but all of the clinical trial data suggests that at some point these will be. And of course, we get really excited about drugs even before they're approved. So this is something really exciting for us here in myeloma. For the BCMA CAR T cells and the therapies associated with it, we've seen somewhere in the 80 to 100% response rate. The most advanced publication that we have is the New England Journal publication of BB2121, which showed a PFS, median PFS of 11.8 months. So that was really encouraging considering the patients were very heavily pretreated with the median of 7 lines of prior therapy. Our second class of drugs, the bispecifics, looks to engage T cells and bring them together with BCMA positive plasma cells. We don't have as much data here. Really, one drug has shown some data so far, although others are in clinical development. So that drug's the AMG 420, which is a clinically used anti-BCMA bispecific T-cell engager, or BiTE, as the company likes to call it, and it's a continuous infusion. So far, they've seen 70% response rate at their MTD. They did have some adverse events related to pneumonias, infections, and polyneuropathy, but I think as we get more used to using these drugs and understand how to use them maybe in a longer-acting form, they will be something that's more available even in the community, as we've seen with blinatumomab. Finally, there's the antibody-drug conjugates, a drug developed by GSK, belantamab, mafodotin, and or as we call it, the GSK drug. And this looks at an ADC, which is anti-BCMA, but deploys the MMAF toxin inside the cells. And this actually has shown a really nice response rate of 60%, and the median PFS in this trial is about a year also. So now we have 2 different agents that have some long-term follow-up in a very heavily pretreated patient population, and they're showing about 1 year of PFS, which is actually really great in this population. I think ultimately we'll have to see what we do about availability and cost. With the ADC, there's been some corneal toxicity, but mostly grade 1 and 2, so probably manageable. But I think this all points to the fact that we have a really brand new class of drugs that we hadn't had before, and I think 2020 is going to see a lot of approval for this and a lot of implementation, not only in academic centers, but we're really hoping also in the community so that more patients can have access to drugs that they couldn't have even dreamed about before.